This is the name of my talk. And I want to start by thanking the folks at Haruv who have made this all possible. I've had wonderful conversations and emails for many months with Paula David, who's been extraordinary, and with Asher Ben Aryeh, who I'm so grateful to for inviting me. We've tried many years for me to do this, but I'm not able to travel to Israel over the last few years. So I'm grateful to be able to do it on Zoom. I want to thank my dear colleague and friend, David Oppenheim, for agreeing to be my discussant, Alicia Lieberman for, being a dear friend and, really an inspiration. I've worked for many years with colleagues at my Minding the Baby program, and I want to thank all of them. And also for the last 5 years, I guess I've been working with an intensive in-home program at Yale called ICAPS. And I have learned so much about complex parents from working with that program, which essentially works with families when everybody is much older and things are much worse and just incredibly difficult. And I'm going to talk a little bit about a tiny bit, if I get to it, the work of my colleague, Victoria Staub, who I know has done some work for Haruv and her work in this area, which I think is highly relevant. So, okay, so toda rabba to all of you. I really appreciate it. And also to Hila, who I know is in the background making a lot of things work. So thank you so much to all of you. I wanted to start today. I asked Alicia, I asked her what she felt Patricia had, what her primary contributions to CPP had been, since I knew Patricia. She was enormously helpful to us when we were getting Minding the Baby started and actually working out our supervision plan, which she consulted with us on. But I asked Alicia what, she felt had been Patricia's contribution. And, they were incredibly close and very dear friends and working colleagues. And as many of you know, the loss of Patricia was very traumatic for Alicia. And what she said was, it's so hard to put into words. All I could come up with were visual images and visceral sensations. It was like losing a part of myself. And I think those of us who work with loss and traumatic experiences can really resonate with that challenge that she felt in coming up with anything, sort of coherent about this extraordinary person with whom she was so close and worked so closely and created this marvelous model that we all work within. And so she referred me to Chandra. Actually, she sent my request on to Chandra, who responded with such wonderful, concrete feedback that I thought I would share it with you. Her major contribution was to provide the organizational stability and her regulatory presence that enabled Alicia and the team to do the work that allowed for joint learning. She helped us move from a dyadic model to a model that incorporated multiple family members as she spearheaded the co-parenting program. To think about, and these are all, for any of you who work in this area, and I assume almost all of you do, to think about how to partner with other systems, including the courts, domestic violence shelters, restraining order clinics, etc. She led the training of the clinical research team so that they were really able to gather research in a clinically sensitive way. That's so important. You can do research without taking into account your population. It can be very, very problematic. She provided the foundation for how to train in CPP, and she partnered with the National Traumatic Stress Network to create the learning collaborative that CPP uses today. So she was a kind of glue that was just so essential. And, her loss still reverberates today. And I thank you, Paula, for showing us that wonderful clip of her. That was really great. Now, I'm just going to start by saying 3 different things. One is, don't worry about reading my slides. I have a terrible habit, which is too many words on my slides. I will explain everything that's on the slides and say much more. So do not drive yourself crazy trying to read my English slides. The second thing that I wanted to say is I often wonder when I think about this particular problem that I'm going to be talking about today, whether this is something we all know and that it's obvious, or whether it bears repeating. So I'll be interested to hear from you whether you feel like this is as important an issue as I do. So we'll take that there. And the last thing is, as I've been preparing this talk, I keep being reminded of something a colleague of mine said when we were giving a workshop for teachers. And what she said to me and to the teachers as we were doing a workshop, she said, the kids are easy. It's the parents who are so challenging. And I think that's true for teachers. I think that's true for therapists. You know, it's really our ability to get to, not get to the parents, but to really connect with the parents is so essential and can be so difficult. So I thought I would start with a brief introduction or framing my talk in terms of Selma Freiberg's remarkable work, which of course gave birth to CPP, and Alicia was a student of Selma's. And there's such a developmental, there's such a story here. And this is the quote that I think really started the infant mental health movement and was the root of all the work that we do. In every nursery, there are ghosts. There are the visitors from the unremembered past of the parents, the uninvited guests at the christening. Under all favorable circumstances, the unfriendly and unbidden spirits are banished from the nursery and returned to their subterranean dwelling place. The baby makes his own imperative claim upon parental love, and in strict analogy with the fairy tales, the bonds of love protect the child and his parents against the intruders and the malevolent ghosts. In some families, and these are the families we see, intruders from the past have taken up residence in the nursery, claiming tradition and rights of ownership. They have been present at the christening for 2 or more generations. While no one has issued an invitation, the ghosts take up residence and conduct the rehearsals of the family tragedy from a tattered script. Each time I read that, it gives me chills. Selma Freiberg and her colleagues were called in by social services outside of Detroit, Michigan, to work with families where the children were about to be removed. And so the social service workers were, you know, I think we would say they just didn't know what else to do. And they really wanted to try to not break up these families. The babies were very young. And Freiberg intervened along with a team of very experienced clinicians. They were all psychoanalytically trained. They were all, you know, quite experienced with 20, 30, 40 years of experience. And the parents they were asked to intervene with had long histories of trauma. The first thing they did, if you read their paper, which is, of course, one of the most amazing papers, is they referred the mothers out for psychotherapy. And this was unsuccessful because the mothers had long involvement often. Well, actually what they had was a sense of, I'm not crazy. I don't want to be treated as crazy. Don't send me out for psychotherapy. And the person they referred to Mrs. March to was a man who was relatively young in the profession and, you know, probably just intimidating for Mrs. March. And it was unsuccessful. She stopped going. And this experience of having to work with a mother and baby together, or that was their genius, is realizing they could work with a mother and baby together, that started the model. Now, what Selma said in that initial paper, the Ghosts in the Nursery paper, is that the child's experience allows the therapist to access the parent's buried affect. That by getting the parent to see the child, which having the child in the room, Selma refers to as having God on your side. And through this process of the parent slowly being able to identify experiences in the child, they come in touch with their own pain. So the parent slowly comes to see the child. And this leads to a fundamental change in the parent-child relationship, but also in the mother's understanding of herself. And one of the main quotes in that paper, one of the central things that she says is when the mother's own cries are heard, she will hear her baby's cries. And that is really the theme for this talk today. When the mother's own cries, or the parents, or the father's, or the grandmother's own cries are heard, she will hear her baby's cries. Alicia and Patricia together expanded on this model to develop CPP. And then Chandra joined the team, or she was there at the time that she had already been working with them at the time that Patricia died. They created an evidence-based manualized intervention that has been tested in 5 randomized control trials and multiple other studies. It's been broadly implemented around the world, as Paula noted, and it expanded infant parent psychotherapy by working up children up to the age of 6 with a specific focus on trauma. And that's been Selma Freiberg talked about trauma when nobody was talking about trauma. And then, Alicia really took that and ran with it in an extraordinary way. And obviously Patricia, as well. In both models, the miracle of change depends upon our ability to reach the parent. If we cannot reach the parent, we cannot reach the child. And our challenge as clinicians is to penetrate the parent's defenses. And this, I'm going to talk much more about defenses, but this can be so difficult because we have to develop a partnership with the parent or the caregiver in order to reach the child. And the more traumatized or challenged the parent, the more challenging this can be. And I think just from what I've heard in the last, 30 minutes, you all are in Israel are particularly, there are so many layers of trauma that many of the families that you work with have to deal with: historical trauma, the violence of war, of displacement, of immigration, in addition to all of the kinds of familiar trauma that we're very familiar with. So this is and there are sort of, well, I'm only going to show you 2 today, but there are kind of 3 graphics that I work with all the time. And this is one of them, which is that we come into our intervention so concerned about the child. But unless we can, I think of this as a kind of Winnicottian drawing, we hold the parents and support them so they can hold the child, but the holding environment is provided first by us for the parent, and then that allows them to hold it for the child. And we certainly in our therapeutic work do a lot of holding for the child. But if we don't have the parent with us in some sense as our partner, we can really be struggling mightily. So today what I want to focus on is the particular challenges of working with traumatized parents, which I think have a number of implications for clinical practice and clinical training. And I'm just going to again acknowledge Chandra here, who I know in her training speaks about 2 scoops, ice cream scoops. There's the child scoop and the adult scoop. And I think that the adult scoop has been somewhat neglected. And so I want to talk about the adult scoop and the impact of parents' trauma-related pathology on our work. So the background for this is about 21 years ago now, we developed Minding the Baby, which is an intensive interdisciplinary reflective home visiting program. The goals of our intervention were to promote secure attachment and relational health by supporting parents' mentalizing capacities. Now, mentalizing is a really unfortunate word. I don't even know how it translates into Hebrew. I hope my translator's given some thought to that, but it's a fancy word for much of what we try to support. That is, I think when you read Selma Freiberg's original papers, you can see that this is very much what she was trying to promote in a parent. And you can see it in CPP, in Circle of Security, we're trying to get parents to envision the thoughts and feelings of the child, to wonder what's going on with the child, to be curious about what they're feeling, to be willing to engage with that, to say in a variety of ways, whether it's in action or in words, I see you, I want to know you, I'm curious about you, and I am open to you. That is a stance that is so difficult to achieve in our work at many times. because it involves a move from being defensive and protected and lost in one's own struggles to really seeing the child. And that is really the process that I'm so interested in. We were working with highly traumatized parents with histories of physical and sexual abuse, parental addiction, abandonment, family, all of the things that we know so well. Many of them had immigrated from other countries. Many of them had been involved in child protection as children. So they themselves had been in foster care, and they themselves had been removed from their own homes. Many were homeless. All of them were chronically very, very poor. And they, of course, had real difficulty being able to stand in a position of curiosity toward their child. That is, mentalizing was very difficult for them. They couldn't, if you will, they were in a state of survival mode, which I'm going to talk about more. And when you're in survival mode, it's so difficult to stand back and be able to imagine what's going on in the person's mind. And this is really what they were struggling with. And it's so difficult when you're in survival mode to access your feelings about another person, to access your curiosity about somebody else's feelings, to say, what are you feeling? And, why'd you throw that toy across the room? Were you mad at me? Was there something I said? Just those simple things, rather than you stop that right now, where it's just more of a fight flight response, which I'll talk about more. So our challenge was building reflective capacities in traumatized parents. Now, I'm going to play with my Zoom just a little bit here, because at the moment I can see mostly not people's faces, but black screens. So I like to be able to see people's responses. So that was our challenge. And what this led me to think a lot about this problem, because you teach trainees and colleagues about mentalizing, and they get very focused on how to get parents to be reflective, how to get parents to have reflective functioning. And the problem with that is that they're not thinking about what has to precede the development of reflective capacities. And this led us to a model which I call the relational foundations of reflection. And this is the relational foundations of reflection. Okay? The top triangle is what we're trying to get to. That is, being able to reflect on one's trauma, being able to think about what's going on in one's child, to be able to take and learn from information, knowledge, to be able, for the parent to be able to explore other options, other ways of thinking about it, for the child to be able to explore. All of these things are our goals. And again, if you read back of Freiberg's original Ghosts in the Nursery paper, you can see that very clearly, that that's what she's aiming for. But that cannot be achieved unless the foundations are established. And the first of these, I think of, the first triangle, I think of as safety, right? That's and regulation. And I'm going to explain this to you a little bit. But until an individual feels safe and regulated, and you can think of this in the attachment paradigm, until the child feels safe and regulated, they're not open to really forming a relationship and to becoming attached. And of course, part of their attachment derives from being continuously helped to feel safe, continuously be regulated. But when there are disruptions in safety and regulation, then you see insecure attachment. And that triangle in the middle is kind of squished, because the child is either preoccupied with safety or and usually at the same time regulation. So let me draw this out for you a little bit more. And let's start with safety. So the first thing to say about safety is, the first thing I'm going to say is that threat is a very common human experience. Babies have little threats all the time. Mom, let's think of a good threat. The dog comes barking in the room, right? A door slams. And the child's first instinct, the baby's first instinct, is to seek safety. That is evolutionarily programmed. We are primed to seek safety from someone stronger and wiser in the case of danger, right? And our biology, and this is the wonderful work, relevant work of Stephen Porges, is to always be checking the environment for danger. That's something we do automatically. That's a physiological system that's in place in everybody. You know, your physiological systems right now, I assume all 150 or 160 of you are relaxed right now. You're not screening for danger. But if anything happened, you know, like, you know, I live on a road. If something loud happened out there, I'd be responding to it. And the point is Porges makes the point that when babies are threatened, human beings are threatened, their chest caves in, their shoulders cave in, they don't make eye contact, their voices flatten out, they don't speak in a prosodic way. They're not, he talks about this, they're not open for social engagement when they're in a state of threat. And there's, you know, tons of neuroscientific research on this. So a person who's in a constant state of threat, that part of their brain, the amygdala, you know, which Patricia mentioned, the emotional brain, the limbic system, is activated so that they're in a position of threat and not responding to the outside world. Okay. So many of the children and the parents we see are in a state of threat. Now, what happens, I'm going to skip all these slides with all the words on them because I know what they say. What happens when a person is in a state of threat? When a person is in a state of safety, they're regulated. And I thought that was so wonderful that Chandra talked about Patricia's regulatory capacity. But when we're safe, we're open, we can breathe, our heart rate is at a normal rhythm, our cortisol levels are low, in a good place, we're taking in information, we're regulated. But when we feel threatened, Porges talks about 3 stances we take when we're threatened. One of them is fight. You know, I'm gonna fight because I feel threatened and I'm gonna be on guard. One is flight, which is I'm threatened and I'm just gonna disappear. And it really means flight as in avoidance, flight as in just staying away from whatever is threatening you. And freezing, of course, fight, flight, freezing is the most primitive defense. And it's the defense we use when we're simply overwhelmed and we're completely dysregulated. And I think that a lot of the families we see are in varying states of fight, flight, or freezing. They are in survival mode because they are chronically threatened. Now, there's 2 ways to think about this. One is when you're feeling relatively safe and relatively regulated, you can be open to a relationship. You can be open to connect. When you're in survival mode, you can't connect. That's the whole wonderful thing that Porges talks about your body being closed or open. You know, when you see people ready for relationship, they look at you in the eye, their shoulders are open, their chest is open, they're speaking coherently. And I think we see this difference in our research all the time. And relationships are critical to making living beings the humans that they are. We become who we are through relationships. And Fonagy now talks about this as the we mode, you know, that we're kind of in this together. We're thinking together, we're partnering together. And this is one of the things that we count on as clinicians, is being able to form relationships with the parents and the children that we work with, is to get into this we mode with them, where we're thinking about what's going on and how they're feeling and so on. And this is, and the getting into this relationship is what allows us to move to the higher triangle of reflection. But these foundations have to be established first. This is why we call them the relational foundations, to feel safe, regulated, and open to relationship. And that is what makes reflection, meaning making, mentalizing, insight, to use David's term, play, exploration, trauma processing, all of these things possible. But again, the reason, I'm going to go to this slide actually. I think what is really compelling is that when you're dealing with traumatized parents, children, you're down in these triangles all the time. You're really struggling at this level. People who are traumatized live in the lower triangles. These foundations are unsteady, and I've made lots of diagrams over the years of different kinds of unsteadiness, if you can imagine moving the size of the triangles around. But their parents are stuck in the threat triangle or in survival mode, and often they're quite dysregulated. You know, they're either very angry or very shut down. And obviously this causes profound difficulties in relationships. And if you think about, and again, this is calling on Porges's neuroscientific work, and I haven't spent any time in this talk on neuroscience because that's a whole other direction to go in, but there's really a lot of evidence for these hypotheses at a neuroscientific level. But Porges's whole idea is, one of his many ideas, I should say, is that social engagement, that is to engage in a relationship, depends on safety. If you don't feel safe, and you know, I reiterate this again and again, because I do think we need to think so much about safety in our work with traumatized parents and children, and how we can achieve safety and regulation. So this is just one of my many illustrations of what it feels like to be in a state of threat all the time. So, of course, there are many reasons that parents would be in a state of threat all the time. One is attachment or complex trauma. One is current trauma. We have, you know, I mean, I know you all can think of many, many examples of this. Parenting, you know, parents who are parenting children whose needs are threatening to them because they can't even begin to need them, they can't hear them, they just overwhelm them, or the child is triggering because they have taken on meaning that's far beyond the child. Or of course, what we call in the US, and I'm sure you all use this term all the time now too, toxic stress, which is socioeconomic risk, racism. And I think what you see, you know, in the Middle East is not exactly what we would call racism, but, you know, tremendous, I mean, oppression might be the right word for it, but violence amongst cultural groups and being in, again, survival mode all the time. So I wanted to use the concept of complex trauma to talk a little bit more about what it's really like working with parents who really suffered enormous trauma. And I'll tell you why. I came, you know, I was aware of the work on complex trauma, et cetera, but I read a paper by Christine Courtois, and you know, I can send the references to, I'm sure that there's a way that you can, you know, distribute a few references that, you know, but I read this paper by Christine Courtois, and I said, these are the parents we're working with. This describes so many of the parents we're seeing. And a complex trauma, which is also called attachment trauma, relational trauma, was first described many years ago now by Judith Herman and Bessel van der Kolk. And Courtois, and it's what van der Kolk talks about all the time. And Christine Courtois, who's a psychiatrist who, you know, works with them, wrote this very clear paper about it in 2004. And the way the concept of complex trauma came about is it used to be that the only way you could talk about trauma victims was to use the term PTSD, which has a certain set of symptom clusters. And Judith Herman in particular said these clusters don't fit the people I'm working with who've had prolonged, repeated, and often relational trauma, years of sexual abuse, years of physical abuse, you know, abandonment, etc. So she said these symptoms, PTSD is not enough to describe what these people are struggling with. She said the current diagnostic formulation of PTSD derives primarily from observations of relatively circumscribed traumatic events like war, disaster, and rape. This fails to capture the protean, which means the changing shape the sequela of prolonged repeated trauma, in contrast to the circumscribed traumatic event like a terrible car accident, being in war, which I think could lead to complex trauma too, but you know more about that than I do. Prolonged repeated trauma can occur only when the victim is in a state of captivity, unable to flee, and under the control of the perpetrator. So this was where she started. And she really said, we need to understand much more deeply what trauma does to the body, what it does to the mind, how profoundly it shapes us. And Christine Courtois picked this up in a paper, 10, 15 years later. Individuals exposed to trauma over a variety of time spans and developmental periods suffered from a variety of psychological problems not included in the diagnosis of PTSD, including, and this describes, at least in my experience, so many of the moms and dads we saw, and grandmothers and grandfathers and extended caregiver networks, including depression, anxiety, self-hatred, dissociation, substance use, self-destructive and risk-taking behaviors, re-victimization, problems with interpersonal and intimate relationships, and they added, but I bolded, including parenting, medical and somatic concerns, and despair. And this is what we are often confronting in our work with traumatized children, is these are the parents that we're trying to partner with to access the child so that we can begin to change the child's relational environment. Because if we can't change the child's relational environment, we're often left with the choice of removal, which is an awful, awful choice, sometimes a necessary choice. So what Herman first suggested is that when you're exposed to chronic trauma, chronic fear, chronic relational threat, you adapt. We're born to adapt. That was Darwin's genius. We adapt to our circumstances. And what they described is a series of post-traumatic adaptations. So that when you're working with somebody who has trauma and you're concerned about depression, you're missing the boat, because depression is a symptom of these underlying, what they call alterations or adaptations. And I'm going to go through these one by one. I think I still have time. To really think about these mental health challenges. We talk a lot about trauma-informed work, and we talk about trauma-informed work, trauma work, but it's all mental health work. These are mental health challenges. These are often psychiatric problems. And I want to talk about how these post-traumatic adaptations have a profound impact on parenting that are very challenging for us to deal with. So the first alteration, and again, I'll talk you through this whole slide. You don't have to read it and translate it. The first is alteration in relationships. That is, when people live in chronic abuse, the lesson from abuse is that others are not to be trusted and that intimacy is dangerous. And this is why folks who had chronic abuse, for example, are distrustful, suspicious, don't trust others. Their tendency is to feel victimized and to victimize. And they tend to have disorganized attachment or unresolved, so they've really got core problems in their capacity to trust. What does that do to someone as a parent? Well, the first thing is it's hard to serve as a secure base for a child, to find pleasure in connecting with a child when your stance is one of distrust and insecure attachment, or even worse. Carlin Lyons Ruth has done such wonderful work on helpless and hostile representations of the child. I mean, you can see this so often in case descriptions that they either have given up any hope of taking care of the child, and the child's a monster, or having these awful representations of the child. And they have really disrupted affective communication with miscuing and frightening behavior and so on. And one of the consequences of this is that the parent frightens the child. The second alteration is really troubles with impulse control. So this is one of the, when you're in a chronically traumatic or abusive situation, you don't, all the work of Dan Stern and Barry Brazelton and so many people in sort of the 90s and 80s just talked about how it's in the, and at Tronic, it's in the interaction that we learn how to label our feelings, express and regulate emotions. And so many people who've lived in these situations in relational threat can't do that. They don't know and describe their own inner states. They can't tell you what they're feeling. And often this is manifest in aggressive or oppositional behavior, poor modulation of impulses. That's what they bring to parenting. So they can expose the child to violence because, and I have hundreds of examples of this, or they can expose a child to violence in their lives, or they can expose the child by being violent toward them. They can take risks. They can threaten self-harm. They find it very difficult to label the child's own feelings, and thus they pass on difficulties in regulation. And again, these kinds of difficulties, having a violent, dysregulated parent who can't tell you what they're feeling, who doesn't know what you're feeling, is frightening to the child. That's kind of the drumbeat here. It's frightening to the child. Herman pointed out alterations in bodily functioning. This is really so compelling. One of the things you see in people who struggle with chronic trauma is how much difficulty they have taking care of their bodies. This was actually one of the observations that Vince Felitti made when he developed the ACEs questionnaire, which was that there were tremendous, and all of this is related to ACEs. I mean, chronic fearful arousal is what causes it, ACEs cause chronic fearful arousal, which causes all of the symptoms that we know are associated with long-term stress. So you learn to tune out your body or to be obsessed with your body. And it also leads to your really not taking care of your body. And you see all these poor health outcomes. In parenting, we saw this all the time in Minding the Baby. They wouldn't notice their child's physical cues. They wouldn't notice they were hungry, they were tired. That thing kids do, when they pull at their ear when their ear hurts, or they pull at their eye when they're sleepy. They often ignore it, and not malevolently, just because they weren't tuned into the child's bodies, or they would become hypervigilant and overly protective. You see extremes of this. And you can imagine that this often leads to difficulties with feeding, temperature regulation, sleep. I mean, how many families have you worked with where sleep is just extraordinarily chaotic and disruptive, both in the parent and the child? The net result, the child feels uncared for and abandoned, and they don't learn how to listen to their own body signals. Alterations in attention and consciousness. One of the things that happens is that there's, we see this all the time. This is the root of dissociation, difficulties in attention regulation, memory, executive function. How often do we see this in families we work with and the parents? They can't remember things. They're not good at planning. They're not good at organizing. They can't finish tasks. They have, I could again think of many examples. They dissociate, they have amnesia or hypervigilance. Those experiences of having a parent who's withdrawn and dissociated or hypervigilant are terrifying to the child, who will either feel abandoned or intruded upon. And they are at a loss with developing their own capacities for attention and executive function. And, Carlin Lyons-Ruth's long-term studies from infancy to young adulthood point out that parental dissociation is probably one of the worst predictors of severe psychopathology in an adult later on. And yet withdrawal is one of the things that you see commonly in traumatized parents. And the parent will also have difficulty with the simple things like organizing everyday life for the child, schedule routines. I mean, that's a chronic issue in the work that we do. Alterations in the perception of the perpetrator. So what often happens is, you well know, with, for example, parents who are in a domestic violence situation, they often idealize or denigrate their perpetrators. So that, my husband's really the best guy, he doesn't mean to do this, or he's just a piece of garbage. And, so what we would talk about as splitting. They also take on the beliefs of the perpetrator. My husband says I'm a piece of garbage, so I am a piece of garbage, I'm bad. So just being a parent being preoccupied with perpetrators, with an abusive spouse, for example, or an abusive parent, interferes with the parent's capacity to attach to the child. But the child can also be experienced as a perpetrator, or they can be idealized. And often that takes place in rapid succession. And these are the meat of what we're struggling with in our work. Again, there's alterations in self-perception, so that individuals struggling with complex trauma or attachment trauma often have low self-esteem. They're struggling with shame, guilt, aloneness, powerlessness. I'm damaged, I'm no good. And that kind of stance really makes it hard to convey to a child, you're good and you're whole and I love you. But I'm a bad mother and father, and then the child has so much trouble seeing themselves as worth something and is not damaged. And of course, they have trouble treating the child. I think about a long-term case that I've worked with for many years, an adult man, whose mother was both very mentally ill, and I think she had sort of, really severe anxiety and agoraphobia and all kinds of bodily issues. And she never could convey to him that he was smart and good. And, I feel like part of my work with him is often to say, you're a good person, which he really most of the time cannot see. And he is a good person. I wouldn't say he wasn't, but finally, Herman and Judith Herman and Van der Kolk and Courtois point to, I think of Viktor Frankl's book, Manhood Search for Meaning. Enough trauma can deprive human beings of their fundamental sense of life's purpose and meaning. And this kind of despair that the child is faced with leaches the hope out of them and threatens the child's sense of faith in the universe. And it's way beyond depression. It's really a kind of despair about, and I know we all know how hard this can be. Each of these alterations has a profound impact on basic attachment processes. The fear system is chronically aroused in the child, and both are stuck in the threat triangle. These are the challenges we face all the time. And if, this is how trauma is conveyed intergenerationally. This is how trauma is transmitted intergenerationally. It's one of the things that Mary Main, who sadly died on January 6th, said in her classic paper with Jude Cassidy and Nancy Kaplan, is that attachment representations are built out of a series of actions and outcomes. A child goes to the parent parent responds, that gets internalized. So child goes to the parent, parent responds, that gets internalized. When you think about these 7 post-traumatic adaptations and the experience of going to a parent who treats you as a perpetrator, who treats you as worthless, who can't control their impulses, the parent, who's distrustful, who's, full of rage, that's the intergenerational transmission. Those exchanges over and over and over again are how things get into the child. And that's, when we think about what the mechanisms are, that's it takes place at this relational, in these relational exchanges over and over. So that brings me back to the triangle, and to how important it is to be able to work in these lower triangles. And, I think there's, if you read Ghost in the Nursery, and if you haven't read it recently, I recommend you reread it. But she talks about, getting the mom to this really extraordinary place where she's able to reflect upon her own abuse. And that changes her whole ability to respond to the child's normative signals for closeness and intimacy and nurture. But if you read all that precedes those moments with the mom, they're all working down in the bottom of the triangle. They're all about creating safety for the parent. Now, what are the treatment implications for this? Again, I want to remind you that the parents are the conduit to the child, And the parents' trauma symptoms and mental health difficulties become the clinician's problem. And the inability to address them will lead to treatment failure. Either the parent will feel unheard and disconnected and won't come out of trauma enough to be able to form a relationship. And my experience as a supervisor and a teacher and a consultant is that these kinds of experiences in parents and in interacting with parents leave the clinician feeling unprepared and overwhelmed. And often I think they are unprepared, which is, I think, a significant issue for us as trainers. And I know in the US, what often happens is, you'll have a very traumatized parent and they'll say, well, let's refer them out for psychotherapy, for trauma-focused CBT. Now, none of the programs that we have here in the US to refer parents out to are geared toward complex trauma. They're not geared toward people, living in extreme poverty with homelessness. They're tested out on much more, what's the word I'm looking for? Much healthier populations. And also, there's so much stigma attached and they often usually don't want to do it. We, the child parents, psychotherapists, are it. So what can we do? I take you back to the triangle. Want to create safety. You want to be bigger, stronger, wiser, and kind, to quote the circle of security. I can't emphasize this enough. And one of the things that one of the ways the triangle, kind of the larger triangle or pyramid, whatever you want to call it, came to me, is I was thinking about how clinicians need to prepare themselves before they go into the session. And how much they need to, when they're in a session, really attend to the ways the parent feels threatened. That is, once you start attending to threat, it's there. You can see it, the way they shift their body, the way they look away, the way their sentence trails off, the way they shift the conversation. You have to attend to what threatens, what triggers them. And oftentimes it can be things that you do. You don't mean to, but we can be threatened. We don't think of ourselves as threatening, but the therapeutic situation is threatening. We ask them to remember. These are folks for whom remembering is awful. We ask them about feelings that they have spent decades trying to bury. We ask them to trust us. And I'm going to get back to that in a minute. And if they're threatened, we are developing a relationship with their child. Managing the triad where you are connecting with their child, and this is someone who's really struggling, that can be very threatening. There's a significant power differential. You are privileged. You can have their child removed. You can bring in the authorities. And there are likely to be significant race in the US. There are often race and class differences. And I think in the Middle East, there probably are also tremendous cultural differences that often have to be negotiated, language differences. And all of these threats lead significant potential to feel shame, judged, and disrespected by us. And I want to go back to one thing on the slide. And it's a book that I quote a lot by John Allen, and it's called Trusting in Psychotherapy. And he talks about the skill, I forgot to cite him on this slide, but I cite him on other slides, the skill in being human. That is, one of the things he talks about is that we train people to do particular kinds of therapies, CBT, TF, CBT, all kinds of, since I don't do a lot, I don't know all the initials, but he says we need to spend more time training therapists than we train them in therapies. In other words, I think our humanity, our warmth, our caring, our concern, our willing to be present are the, and there's a lot of evidence of this, our willingness to be present emotionally is what, creates safety in the relationship, not the kind of therapy we're doing, not the curriculum we have, not, it's really our capacity. And there's, as I said, lots of evidence for this in the psychotherapy literature. But so the first place to start is safety. Do they feel safe in that situation? And often the answer is no. Can you support regulation? Oftentimes we use in our work meditation techniques, deep relaxation, breathing, and sometimes it can be as simple, and it often is as simple as, let's take a deep breath, let's pause, I see you're really upset. Usually, you come into a session and the parent is very upset about something. And, I'm going to use the metaphor of flight, fight, or freezing. These are defenses against threat, right? These are responses to threat. When they're in flight and they're escaping and they're going away and they're avoiding, gently encourage them to tolerate emotions. If you go in too fast, they'll disappear, right? But to give them gradually over time, the idea that emotions are tolerable. When they're in fight, again, you see so many parents like this who are, ready to angry about the child, angry about their partner, angry about their life. Gentle encouragement to pause and let go and try to be present to the complexity of the moment, not just all the things that are wrong. And when they're in freeze, and so many, really traumatized parents are in a state of freezing, to remain present as an anchor and gently pull them back in. And these sound so simple on a slide. They're actually very hard and they take a long time. But I'm also encouraging you to think about what kinds of defenses a parent is using when they're overwhelmed. Are they in flight? Are they in fight? Are they completely collapsed? This is again this book by John Allen, which came out in 2022. And he makes the point that when someone's trust has been savaged by attachment trauma, the cultivation of trust and an intimate bond will not be the foundation for therapy or the vehicle for therapy. It will be the work of therapy. So safety and regulation is often where you'll be for a long, long time. And that is absolutely vital. Then I'm not going to read you this long paragraph, but I'll read you the first patient. The development of the therapeutic alliance, a more or less straightforward process with a non-traumatized patient, is often a daunting challenge with one who has been severely interpersonally victimized. They're beset by shame and anxiety. They're terrified of being judged. You can be seen as a perpetrator. You can be seen as someone they need to challenge. The relationship can be sexualized. And I'm sure you've all had a version of that experience. They can cling to you desperately. And all of these are examples of what happens, when they're had these, horrific experience. And so Alan says, we have to be trustworthy first. We have to be somebody that makes them feel safe, but also that they really can begin to form a relationship. And without the skill of being yourself, of being, without the skill of using your humanity to connect with another person. And I think this is particularly hard for less experienced clinicians. By the time you've been doing this 20 or 30 years, you know that you are your most critical therapeutic tool. Your feelings, your presence. But when you're learning, you don't trust that because you feel there are all these things you should do. But you know how to make another person feel a little better. You know how to let them know you're there. You know how to let them know that you're safe. And I just want to acknowledge the work of my colleague, Victoria Staub, who has developed an activity called the family cycle, which is a way of, once you have a relationship with a parent that is fairly workable, this is an activity that allows a parent to trace through their own feelings, their own horrific experiences, and how that led them to feel and how that leads them to act. And what beliefs they end up having about the world, and then how these influence their child. And then you can do the same activity with the child. And it really is a powerful way, not only to get parents to acknowledge their own triggers and their own cycle of non-mentalizing cycles, but also to get them to appreciate how this has affected the child and created similar cycles in the child. And without these, and I think that helping clinicians really understand the complexities of trauma-related pathology in adults is critical, because otherwise they're going to be overly frightened, overwhelmed, judgmental, and directive. It's so easy when you're feeling scared to tell a parent what to do, and usually that doesn't work. Now, interestingly, Christine Courtois wrote this paper on complex trauma, and this idea that I've been aligns directly with her ideas about how to treat complex trauma. She said you have to establish safety, security, and affect regulation. And she said this is often all you do for a couple of years. Now, we don't often have that long, but that's what allows space for social engagement, for the, you think about the parent opening up to you and opening their body up to you and looking at you and engaging with you. That's what makes a relationship conform. And it precedes processing, remembering, and reflecting on trauma. And she describes it so beautifully in the paper that getting to trauma processing is an outcome. That's where you get to when you've been able to establish the rest of this. Again, just to return to the sort of theme of this talk, when the mother's own cries are heard, she will hear her baby's cries, taking us back to now, almost 50 years ago. I think we also have to think about this at a workforce level, right? Freiberg, Lieberman, and their colleagues were very experienced clinicians with experience with adults and children. We need to offer more didactic training in adult mental illness, psychopathology, and diagnosis. And many people will say that's not in my scope of practice. Well, there are actually, without needing to be able to diagnose, just an understanding of what you're seeing and how it's organized and why it's there. And some of the ways of understanding it can be so helpful. The need for clinical supervision, where people are, clinicians are really helped to understand dynamics and defenses and projection, resistance, all these ways of understanding what's going on with families. So important, with parents particularly, and developing ways to hold and recognize trauma and extreme emotional distress. And we all know and have had our own experiences of finding this very, very difficult. Reflective supervision is quite popular in the United States as a way of a clinician managing his or her own strong feelings, which are very much evoked in working with complex trauma individuals, patients, parents struggling with complex trauma. And it's really different from clinical supervision, but I think clinical supervision has kind of gotten pushed aside, and I would be willing to bet that's not true in Israel, but it has gotten pushed aside, I think, in the US, where there's just not enough attention to interpersonal dynamics and defenses. And finally, when you're working in a school or you're working in a daycare center, to have mental health consultation available is so important, so that you're not really left alone with these kinds of experiences with parents and caregivers. So I just want to give a little plug to the book that's coming out in June. Thank you very much, God, where a lot of these issues are addressed and discussed in more time. And we now have approximately, according to my, about 7 or 8 minutes for questions, which isn't 15, but okay, so I'm going to take down this magnificent picture that my friend took. And
Arietta, thank you so much. We have some time for questions. And we have one in the chat already. I'm going to find, one second, by Shoshana, who asked if there's enough research about the connection between chronic abuse and epigenetic changes.
Yes. Actually, I'm my friend Larry Aber, who many of you know, and I think has maybe given this lecture in the past, he would tease me about how I don't always need evidence for my formulations. So I think there may be somebody else in the audience who can answer this in a more explicit way, but there is no question that part of what we're seeing in traumatized adults and traumatized children are epigenetic changes at multiple levels. And, the research on epigenesis is in its infancy, but I could have given this whole talk purely from a neuroscientific perspective. I don't think it's as relevant to you as clinicians, but.
Okay. Thank you. Also, somebody asked if you could put up the name of the book again.
Yes.
Your new book?
Yes, sure. Here we go. There, you got it? There.
There we go.
So I'll leave that up for a few minutes.
Everybody can write that down. We're waiting for it. Any other questions? Questions, comments? You can write in the chat if you want. You can open your microphone if you want to.
You can raise your hand.
You can raise your hand, but I don't know if we'll see that.
If you raise your hand on the Zoom thing, it'll bump you up to the.
I'll bump you up so we'll see you. Okay. You can raise your hand. Sigal. I see Sigal.
Yes, hi.
And bump up. Yes.
Hi. First of all, thank you so much. I think it's not only important, but so inspirational, of course, when we're working with traumatized parents. So really, it fills my heart. So thank you so much. And of course, I think the big question that we are all dealing with is, in Hebrew, we say, the time of the child, the critical time, because you're talking about processes that we know are, they take time, building trust with women, parents that are so severely damaged in relationships, can take a year, can take 2 years. In the meantime, the child is 2.5, he's 3. This is in the good, sometimes it's 4 and 5. And I think we're always debating between the time we want to give the parent, and of course giving the parent is also giving the child, but what do we do in the meantime with the child when he might be developmentally injured? Yeah.
Mm-hmm. Well, I know that, and I should have said it. I think that's a really important point, which is that we don't often have that much time, and often we have very little time. But I think having a frame of I have to create safety for this parent, even if it's within a short window, and I mean, it's very hard, because if you think about the fact that often families come to us in emergency states. I mean, I think about the work I do with this in-home program that Victoria works in the US. They're coming to us in complete crisis, and these kids are older, so you're talking about big crises, and you don't have much time. There's something really terrible is going on, but I think if you think about coming into these situations, not getting ready to educate or give advice, but getting ready to listen, and getting ready to listen as a human being, and try to, you think about what the activation of your emergency system does to another person. Like your being in an emergency state just triggers all of their defenses. Their amygdala is going crazy. They're just feeling like, oh, you're going to take away my child, and you're going to criticize me, and you're going to shame me, and you're going to judge me, and we may not have. I realize, we don't have often a lot of time. But when you think about the kinds of experiences so many parents have with social services, and one of our moms in Minding the Baby used to talk about their game that they played when they were little was a game with dolls called Here Comes the Social Worker.
Wow.
Because they all lived in that experience of waiting for the child, waiting to be taken away from their parents, and how terrifying that was. So by definition, you want to be a different kind of person. You know, you want to be, I said this to a student I was supervising, many, many years ago. I said, you are a kind of creature that this boy has never met, because, he wasn't coming in as a social services person. He was coming in as a listener, and it was a similarly, really difficult situation. So I thank you for pointing that out. But I think that often that allows us to feel defeated already. It takes too long to reach parents. It's too big, it's too scary. But it might be worth, sort of trying to reframe your relationship to it. And I'm sure we all try all the time, but the urgency of the situation is very compelling. I agree. Thank you. That's a great question.
Yeah, thank you. Thank you.
Arietta, can you put your slides down now so we can that thing?
See each other? Yep, sure.
Yeah, thanks so much. We have another question on the chat that I just lost here, actually. Here we go. Do you consider another factor when the child is autistic or otherwise disabled? Yael asks.
Can I consider? I actually wrote a paper about that, and it came out in 2009, and it was in the Journal of Infant, Child, and Adult Psychotherapy. And in that, I'm just going to tell you a little bit about what I wrote about, which is that, sort of by definition, and depending on how far onto the spectrum one's child is, the state of being threatened and dysregulated for parents can be one that's quite constant and chronic, because all the cues that we use to understand a child are absent or very distorted in a child, particularly one who's not Asperger's, but further along the spectrum, so that the parents are in a state of threat, shame often, incomprehension, frustration, and they're often dealt, they often, are confronted with professional environments that say there are all these things that you have to do. You have to try this, try that, there's intensive remediation going on. And, I think many of us have experienced this and do this, but the attention to the parent and the activation, if you will, of their threat system in working with children on the spectrum is so important. They need so much support, because it's hard enough to form a relationship with somebody who's using the same communication system that you are. But it's really hard when the child is in some way, really disrupted in their capacity to communicate. And it, a sort of my constant refrain in terms of work with kids on the spectrum is how much more attention needs to be given to parents themselves and their experiences. And again, it depends on the extent of the child's disability, but it's really hard. I don't know, Anat, if you agree with that.
I'm going to have one more question because we're getting a little bit close, and I see Smadar raising her hand. Hi, Smadar.
Hi, thank you.
Hi,
Hi, how are you?
How are you? I'm good, thank you.
Yeah, thank you. It's really wonderful to hear you each time. It's so enriching and so inspiring. Really, thank you for this lecture. I would like to ask how you would suggest creating safety when the therapist also has to provide a recommendation to the court regarding parents' ability to parent the child.
Well, which by definition is threatening to the clinician and the parent, right? Oh, I had a thought as soon as you asked the question, and now it's gone out of my mind. I think, you cannot really take away that threat. But I think you can say to a parent, I'm going to do my very best to try to understand you and understand your child and to understand the circumstances that you are in. And I will be clear with you and I will communicate with you and I'll be honest with you. And, you know, I have certain things that I have to fulfill, but I'm going to treat you as a human being in this circumstance. One who, and I understand that this is frightening and this is really awful. And I really will do my best to do this in as fair and as open a way possible. I mean, I think that, you know, I think about John Allen's idea about being trustworthy. That makes you trustworthy, you know, because you're telling the truth.
Yeah, absolutely.
But if you deny the threat, you know, that you're feeling, I mean, you're not going to tell the parent that you're feeling anxious too, but if you don't sort of think about it, it just gets in the way.
Thank you. This is really using your humanity, really.
Yes, exactly. That's what we have more than anything else.
Thank you so much. It's really, really, yeah.
I think those are really good closing words, that our humanity is all that we have. And I want to thank you so much for this lecture that we could have continued to listen to for quite a while.
Thank you all. Toda rabba.
Yeah.
I'm going to move on to our discussant, which we are also very happy to have here, who is also a friend of Arietta's, and that is Professor David Oppenheim. And David, one second. David Oppenheim, Ph.D., is a professor of psychology and vice chair of the School of Psychological Sciences at the University of Haifa, Israel. He also has the Center for the Study of Development in that university. Dr. Oppenheim's studies include the role of parental insightfulness and parent-child open communication in dyadic and triadic parent-child relationships from infancy throughout childhood. He studies these questions in longitudinal studies, including typically developing children, children with atypical development, and children at a high risk, such as those in foster care and those whose parents experience trauma. דוד, אנחנו ממש שמחים לארח אותך, והבמה שלך.
תודה רבה. אני האמת שאדבר בעברית, אבל שנייה אחת באנגלית. So Arietta, just thanks so much for brilliant and moving talk. That's what you do so well. And I think that when you talked about humanity, it was your humanity that came across, even though we're thousands of miles apart. And I felt it, and I'm sure that others felt it. And that's the real gift. And that's what we have in these talks that's beyond the papers, that, you know, the papers convey the information, but there's something about meeting you and listening to you. So thanks so much. I've heard you many times, like Smadar said and others, and it's always not only an intellectual experience, but also an emotional experience. Moving.
Thank you so much, David. Thank you. It means a lot to me.
יש לנו את הפריבילגיה של תרגום סימולטני, ואז אני אוכל לדבר איתכם בעברית. רוב הקהל פה הוא מהארץ, וזה בהחלט נחמד מאוד. ראשית, אני רוצה להגיד תודה פה לאשר חרוב שהזמנתם אותי פעם שנייה כבר להיות הדיסקסנט כאן. פעם קודמת זה היה ללארי אייבר, שהוא חבר טוב מאוד של אריאטה במקרה, וכל המפגש הזה לזכרה של פטרישה, שמאוד קשור כמובן לאלישה ליברמן גם, שאני מכיר אותם טוב מאוד, את פטרישה. היה לי הכבוד להכיר גם ולראות את האדם הסופר מיוחד שהיא הייתה, וכל התחנות שהיא עברה בחיים שלה, שינויים והתפתחויות מרתקים, וזה באמת ממש טרגי וטראומטי שהיא עבדה לנו בצורה כזאת, היה לה כל כך הרבה מה לתת, ובאמת בשביל אלישה זה היה גם כן אובדן שקשה מאוד להתגבר עליו, כי הם עבדו ביחד בצורה פשוט מושלמת, השלימו אחת את השנייה בצורה מושלמת. אני רוצה לדבר על אריאטה ועל התרומה שלה, גם מעבר ל-minding the baby, שהיה יותר הפוקוס היום. התרומה החשובה של אריאטה למחקר ולטיפול, ואחרי זה אני אדגיש כמה נקודות שאריאטה דיברה עליהן. אני לא אוסיף, אין מה להוסיף אחרי ארוחה מלאה כזאת, אבל אני רוצה להדגיש כמה נקודות שנראות לי לפחות חשובות, ובסוף אני ארצה לספר לכם גם קצת על מחקר שלנו, איך חוקר מתייחס למורכבויות המאוד גדולות האלה שעלו כאן היום, ולוקח חתיכה אחת קטנה, והנושא יהיה העברה בין דורית של טראומה, ואיך אנחנו במעבדה, במחקר שלנו, יכולים לצפות בתהליכים האלה שהם קוראים לנו מול העיניים. אז ראשית על אריאטה, להגיד כמה דברים חשובים. אני חושב שהיא בולטת מאוד בתרומה שלה לתרגום תיאוריית ההתקשרות לעבודה קלינית. גם פסיכותרפיה אינדיבידואלית, גם הדרכת הורים, גם טיפול פרטני בילדים, וגם כמובן תוכניות התערבות כמו minding the baby. שילוב מאוד מיוחד אצלה של המחקר והטיפול. מבחינת הכתיבה על פסיכותרפיה, אני רוצה להמליץ מאוד על הספר הזה, הוא נקרא Attachment and Therapeutic Practice, שאריאטה כתבה יחד עם ג'רמי הולמס, ספר מדהים מבחינת היכולת שלו לתרגם מושגים מתיאוריית ומחקר ההתקשרות לעבודת פסיכותרפיה בצורה מלאת חיים, חיה ואמיתית, תוך היכרות מאוד מעמיקה עם המחקר בהתקשרות, הרבה יותר מאשר רוב האנשים שעוסקים בתרגום הזה. הפניה נוספת שאני רוצה היא לפרק בתוך ספר, סליחה, זה ספר שאני ערכתי, אני לא מנסה לקדם פה את עצמי, אבל הספר נקרא Attachment Theory in Clinical Work with Children, ובתוך הספר הזה יש לאריאטה פרק שנקרא Disorganized Mother, Disorganized Child, a mentalization of affective dysregulation and therapeutic change, the mentalization of affective dysregulation and therapeutic change. ומה שהיא עושה פה, שאני לא ראיתי אף אחד עושה כל כך טוב, זה לקחת את המושגים של דיסאורגניזציה של התקשרות, הישר מתוך עולם ה-adult attachment interview ועולם ה-strange situation, לפרק בעצם לעומק את המושגים האלה, ולהראות איך בעבודה עם אם ועבודה עם ביתה, למעשה עבודה נפרדת, הבת היא מתבגרת, אז זה שתי פסיכותרפיות נפרדות, המושגים של דיסאורגניזציה עוזרים לאריאטה להבין מה קורה שם ומה לעשות, בצורה שהיא מאוד גם experience near, השפה שהיא משתמשת, מתחברת לחוויה, ואני חושב שזה תרומות מאוד מאוד מיוחדות וייחודיות. אין עוד הרבה אנשים, אולי ג'רמי הולמס גם כן, שמסוגלים לחבר את חקר ההתקשרות העדכני עם העבודה הקלינית בצורה חיה ותוססת כל כך. התרגום של אריאטה של תיאוריית ההתקשרות לעבודה הטיפולית יצירתי ומעמיק, מתבסס על היכרות עמוקה עם התיאוריה והמחקר. היא מתבססת כמובן על שורשים פסיכואנליטיים כמו וויניקוט, על השפעות מהעולם של infant mental health, על עבודה של דמויות מכוננות כמו סלמה פרייברג, שמענו היום המון, סלי פרובנס ואמירתה האלמותית embrace complexity, וגם כמובן על חוקרות בנות ומטפלות בנות זמננו כמו אלישה ליברמן ו-child parent psychotherapy, פיטר פונגי וכל העבודה על מנטליזציה, וקרליינס רות שאריאטה הזכירה, ואני רוצה מאוד להדגיש אותה כי היא פחות מוכרת אולי לחלק מכם, וספציפית היא דיברה, קרלן מדברת על הקשר בין hostile helpless states of mind, מצבי תודעה עוינים וחסרי אונים מתחלפים במהרה מצד לצד, מתרגמים להתנהגות הורית משבשת, disrupted maternal behavior, עם כל מיני סוגים, יש מערכת קידוד לדבר הזה, אנחנו גם השתמשנו במעבדה כאן אצלנו, והתקשרות בלתי מאורגנת אצל הילד. כל השרשרת הזאת היא כל כך רלוונטית לעבודה הקלינית, ורמת הדיוק של העבודה של קרלן היא באמת יוצאת דופן בעניין הזה. אני חושב שכשאני אומר היכרות מעמיקה עם תיאוריה, מחקר, עם כלים כמו strain situation, adult attachment interview, parent development interview, שזה כלי שאריאטה פיתחה, pregnancy interview גם היא פיתחה, אני מתייחס לכך שבגלל שהיא עבדה עם הכלים האלה, ומכירה אותם לעומק, היא מתייחסת לא רק לקטגוריות, אתם יודעים, בטוח, לא בטוח, מאורגן, לא מאורגן, אלא לתהליכים שהם מתחת לקטגוריות האלה. למה רגישות ומנטליזציה, למשל, תורמים לביטחון? איך זה עובד? מה החוויה של הילד שההורה חושב עליו בדרך שמערבת מנטליזציה, התייחסות למניעים ולעולם הפנימי? איך זה תורם לביטחון של הילד? לא רק בהורה, אלא גם בעצמו, בתפיסה שלו את העולם. מה קורה לילד שההורה שלו אינו חושב ככה? כיצד מרגיש ילד שאינו מוגן, ושתפיסת המציאות שלו מעורערת על ידי סביבה בלתי קשובה? יש הרבה דרכים להראות קשיים בחוסר מנטליזציה, ולכל אחת מהן השלכות ספציפיות. כיצד משפיעה למשל התייחסות רק לרגשות חיוביים של ילד ולא לשליליים? כיצד משפיעה העצמה של פחד? כיצד משפיעה חשיבה מבולבלת או מנותקת על הילד? ובמיוחד בהקשר של היום, איך פחד, מצוקה ללא ויסות, איום, סטרס מציף. אריאטה נכנסת לעומקן של כל השאלות. עוד דבר שמאפיין את עבודתה של אריאטה הינו השימוש בשפה הקרובה לחוויה, תרגום של מושגים מקצועיים כמו רפלקטיביות, מנטליזציה, למשפטים כמו אני חשוב למישהו, יש מישהו שיקח את הצד שלי, יש מישהו שאני שייך לו, שאני הכל בשבילו. אריאטה ישירה, מדברת בשפת היום-יום, גם על המושגים המופשטים והמורכבים. תרגש מרכזי אצל אריאטה הינו למרכזיות של פחד, איום, ההרס שהם זורעים אם הם לא מבוסתים, לא מוכלים, אם הם מגיעים לרמות שהילד מוצף, כך שאינו יכול להפעיל מנגנוני התמודדות בצורה יעילה. זה toxic stress. הסטרס הזה מונע את הגמישות ואת הפתיחות לחוויה ולחשיבה, שכל כך חשובים בהתייחסות לעצמנו ובהתייחסות של ההורה לילד. נקודה חשובה שאני רוצה להדגיש כרגע, לא שהשאר לא. חוט שני שעובר בכתיבה של אריאטה, הוא שהתקשרות לא בטוחה, מנגנוני הגנה, סימפטומים של טראומה מורכבת, כולם אלה התמודדויות, אדפטציות. דפוסים שנקראים לא אדפטיביים, אולי בראיית על, כאילו לאורך החיים, אבל הם לגמרי הגיוניים אם מביאים בחשבון את ההקשר הרגשי, את הקשר היחסים ואת הפגיעה ביחסים שבתוכם הם התפתחו. הגיוני לגמרי שילד שחווה דחייה יפתח סגנון נמנע. זאת הדרך שלו להשיג את מקסימום הקרבה ההורית שהוא יכול לקבל. הגיוני לגמרי שהתנהגויות המעידות על התקשרות בלתי מאורגנת, כמו דיסוציאציה, הן פתרון לרמות מצוקה מציפות, מעל ומעבר למה שהילד יכול להכיל. אם אנחנו חושבים על זה ככה, זה הרעיון שהיא מפתחת בפרק הזה שדיברתי עליו, disorganized mother, disorganized child. זה מאפשר אמפתיה והסתכלות על העולם דרך העיניים של המטופל, ובמיוחד דרך העיניים של הילד שהמטופל היה פעם. ואריאטה מראה בפרק הזה איך היא משתמשת בתצפיות שהיא מכירה מהמחקר על התקשרות, בעצם כדי להתחבר אל החוויה של מטופלת שהיא היום בוגרת, שהיא אימא, ואיך זה היה בשבילה כשהיא הייתה כל כך מאוימת על ידי האב במקרה הזה. לב ההתערבות, הגברת המנטליזציה, או התובנה, כמו שאנחנו קוראים לזה, של ההורה בהתייחסות אל הילד.
דוד, לא שומעים
דוד,
אותך.
דוד, אתה נהיית על מיוט בטעות.
סליחה. לב ההתערבות, הגברת המנטליזציה, כמו שאמרתי, והתובנה של ההורה בהתייחסות אל הילד. הורה שחווה איום, פחד, נמצא במצב הפוך לחשיבה רפלקטיבית. וכדי שהוא יזוז קצת לכיוון יותר רפלקטיבי, הוא חייב להיות מבוסת ולהרגיש בטוח בקשר איתנו. שאנחנו שם לצידו, מקשיבים לחוויה שלו. זה יכול להיות קשה מאוד, במיוחד סביב תכנים מלחיצים מהעבר או מההווה, שיכולים להכניס אותנו, כך מראה לנו אריאטה, לעמדה שופטת, מייעצת, מתקנת, עוזרת, כל דבר רק לא מקשיבה. זה ברור וטבעי, אך משהו שאנחנו צריכים להבין ולהכיר, והרבה פעמים אנחנו צריכים הרבה עזרה של הדרכה בשביל שמישהו יחזיק אותנו. אלה היו כמה נקודות מתוך השפע שאריאטה הציגה בפנינו, שנראו לי חשובות במיוחד, ואני רוצה עכשיו לעבור ולתת לכם שתי דוגמאות קטנות, קצרות, מתוך מחקר שלנו, שידגימו איך אולי המושג הזה של העברה בין-דורית של טראומה, איך זה קורה, למשל, דוגמה אחת, בשיח בין הורה וילד. במחקר שלנו שאלנו מה קורה בשנים שלאחר הינקות דווקא, כאשר שיח, ובמיוחד שיח רגשי, הופך להיות חלק מהיחסים והאינטראקציה. חקרנו את השיח הרגשי בקרב מדגמי קהילה, בהם איננו מצפים לרקע של טראומה, אך גם בקרב אימהות שחוו טראומה בילדות, וזה מאוד מתקשר לנושאים שאריאטה העלתה היום. בולבי הדגיש את החשיבות של השיח הרגשי הקוהרנטי, המקבל והאותנטי לגבי החוויות הרגשיות של הילד עבור ההתמודדות של הילד עם חוויות קשות. בספר הזה של בולבי, שנקרא בסיס בטוח, באנגלית A Secure Base, יש פרק שנקרא על הידיעה של מה שאין אמורים לדעת וההרגשה של מה שאין אמורים להרגיש. פרק מבריק, אלישה גם כן מצטטת הרבה ממנו, שמדבר על דפוסי תקשורת בשנים אחרי הינקות, וכיצד בעצם ניתן לשבש את הבסיס הבטוח של הילד, ואנחנו לקחנו את הפרק הזה כהשראה למחקרים שלנו. בולבי מדבר על החשיבות של השיח הרגשי הקוהרנטי, המקבל והאותנטי לגבי החוויות הרגשיות של הילד, עבור ההתמודדות של הילד עם חוויות רגשיות קשות. והוא באופן משלים, הוא הדגיש את הנזק שנגרם לילד, כאשר המבוגרים בסביבתו נמנעים מלדבר על חוויות קשות שהילד עבר, או עוד יותר גרוע, מעוותים את המשמעות שלהם. הוא מביא כדוגמה פגיעה מינית, כאשר ההורה הפוגע מציג את הפגיעה כאהבה, כקשר מיוחד, או מאשים את הילד. נוצר פער בלתי נסבל אצל הילד בין חוויית פגיעה, חילול, לבין הייצוג שלה בשיח, מלווה לעתים קרובות באשמה, בושה ותחושות של אחריות. זה כמובן חלק אינטגרלי מ-CPP, העבודה על השיח הזה. אנחנו שאלנו את עצמנו אם אפשר לאפיין שיח שמהווה בסיס בטוח לחקירה ורפלקציה וכזה שאינו. אני רוצה להביא שתי דוגמאות מתוך מחקר על ההורות של אימהות שחוו פגיעה מינית מתמשכת בילדות מאדם קרוב במשפחה. זוהי עבודה משותפת עם דוקטור רחל, אז דוקטורנטית, היום דוקטור רחל גצלר יוסף, ופרופסור נינה קורן קרי. הפגיעה בתוך המשפחה קשה במיוחד, כי היא מערבת דווקא את היחסים שאמורים לספק לילד הגנה וביטחון. האימהות גויסו למחקר דרך מכון המעניק טיפול לנשים שחוו פגיעה מינית בילדות. אני רוצה לספר לכם או לתת לכם שתי דוגמאות. האחת מדגימה שיח מותאם רגשית בין אם לילדתה, בו האם מהווה בסיס בטוח לחקירה של העולם הפנימי של הילדה, למרות שלאם זו פגיעה מינית בעבורה. השנייה תדגים לנו כיצד אם עם רקע דומה מתקשה להוות בסיס בטוח. היא מתקשה ללוות את הילד במקום בו הוא נמצא, ולמרות כוונותיה הטובות, כופה עליו נקודת ראות הקשורה, אולי, לטראומה אותה חוותה. אנו רואים כאן את העברה מתרחשת לנגד עינינו, לא כתהליך מסתורי או סמוי מן העין, אלא באופן גלוי לחלוטין. הדוגמאות שאני מביא הם לא ציטוטים מדויקים, אלא שילוב של דוגמאות מתוך שיחות של מספר אמהות וילדים. מי שמעוניין לדעת יותר מוזמן לכתוב לי ואשמח לשלוח את המאמר שבתוכו הדוגמאות האלה מופיעות ויש שם הרבה יותר פירוט. מה לגבי הפעם שפחדת? שואלת את האמא את הילדה בהתאם לבקשה שלנו, כן? את זוכרת, אני תמיד אומרת לך שאני מפחדת מהחושך, אני מפחדת שגנבים יבואו. אני זוכרת. אני מפחדת שכשאני ישנה, גנבים ייכנסו לבית. מה את עושה כשאת מרגישה ככה? אני מכסה את עצמי עם השמיכה. עושה עוד משהו? אני עוצמת את העיניים לראות אם זה עוזר, ולפעמים אני קוראת ספר. כן. אני מנסה להירגע ככה. כן, את צודקת. את זוכרת שאתמול אמרת לי שאת פוחדת? מה ביקשת ממני? אמרתי שאני רוצה להשאיר את האור דולק כל הלילה, כי פחדתי מהחושך. נכון, אז ישנתי עם האור ולא פחדת. כן, זה עזר. האם מקבלת את האירוע שהילדה מציעה כאירוע מפחיד? אני אומר את זה כי לא כל האימהות מקבלות, יש להם תוכנית על מה הילדה צריכה לדבר. ועוזרת לה להרחיב את הרעיון, בהתאם לבקשתנו, להרחיב אותו, אך לא להעצים אותו. ואין הסתה של השיחה אל האם, כמו שקורה לפעמים. הם מדברים על פחד באופן מבוסת ופתוח. אחרי שהאם קודם כל מקשיבה לביתה, היא מכוונת את השיחה לדרכי ההתמודדות שלה, לכוחות שלה. זה secure attachment, זה ההרגשה של ילד יותר גדול, אני יכול להתמודד כבר עם הדברים. הילדה משתפת פעולה ומרחיבה על הדרכים שלה להירגע. האם מכוונת את השיחה לאירוע ספציפי, והילדה מספרת על האירוע והפתרון שלה, להדליק את האור ולישון עם האור דולק. האם מקבלת את זה, מכוונת את השיח, מדגישה התמודדות וכוחות, ללא העצמה, תוך שמירת מוקד השיח על הילד. שיח כזה, אנחנו רואים אותו כבונה את הבסיס הבטוח הרגשי, the psychological secure base. אותו בסיס בטוח של יציאה מבסיס האם לחקירה של הסביבה, רק שהפעם החקירה היא של העולם הפנימי, לא החיצוני. מעבר לביטחון, שיח כזה מקדם יכולות של ארגון קוהרנטי של החוויה הרגשית ותקשורת רגשית פתוחה, כל המאפיינים של התקשרות בטוחה. ובנוסף, וחשוב מאוד לעניין העברה הבין-דורית, למרות הטראומה שעברה האם, היא מסוגלת להפריד בין העבר שלה לבין האינטראקציה עם ילדתה, מה שקשור כנראה אולי ליכולות הרפלקטיביות שלה. נראה עכשיו דוגמה שבה האם יותר מתקשה אולי להפריד בין החוויה שלה לבין החוויה של הבן שלה הפעם. מתי אתה זוכר שפחדת? כשהלכתי לישון אצל רון, ורון נורא פחד. רון חשב שיש לו מפלצת בחדר, אבל בכלל אין לו. אין לו? לא, לא, אין לו. ואתה חיפשת היטב את המפלצת? מה קרה לה? אבל אין שום מפלצת, את לא שומעת אותי? אתה בטוח שלא הייתה שם שום מפלצת? אולי התחבאה איפשהו? לא הייתה שום מפלצת. לפעמים הן מתחבאות. היה שם זאב גדול עם פרווה שחורה ואוזניים גדולות, ואני דרכתי על הזנב השמן שלו. ככה. אתה ממש ילד גדול וגיבור שלי. מבחינת האם, השיחה מושתתת על אמונה נחושה שמפלצות קיימות, וחוסר יכולת לקבל כאשר הבן אומר לה, אין מפלצת. היא מתקשה לראות את הדברים מנקודת ראות שלו, וכופה עליו את התפיסה שלה, שמפלצות קיימות ושיש להילחם בהן. כשרון אומר שאין מפלצת, היא לא מקבלת את זה, דורשת שיחפש אותו. בהתחלה הוא נלחם על עמדתו, אין מפלצת, את לא שומעת אותי? אבל האם מתעקשת שהיא ישנה, שהיא מתחבאת, שיש לחפש אותה. רון נתון בין הפטיש לסדן, לדבוק בתפיסה שלו זה להתנגד לאמו, וילדים יעשו הכל על מנת לשמר את הקשר והקרבה עם ההורה. זאת הנקודה שאריאטה מדגישה כל כך בדרך שבה היא מציגה את תיאוריית ההתקשרות. הוא נכנע, הוא ממציא מפלצת ויודע גם מה הציפייה, שהוא יהיה גיבור וילחם בה. הוא דורך על הזנב שלה וזוכה לגמול דברי שבח שלהם שהוא גדול וגיבור. את הרקע לקושי שלהם ניתן לראות, את הרקע לקושי שלהם לראות את העולם דרך עיני הילד, בנפרד מהחוויות שלה ולהוות בסיס בטוח לחקירה, ניתן לראות מראיון התובנה שעשינו לה. הראינו לסרטון שבו הצגנו לרון התחלה של סיפור עם בובות, בו הילד מתעורר בלילה לשם הקולות, ואומר, יש לי מפלצת בחדר, כן? זה הסיפור של הבובה. רון המשיך את הסיפור בכך שהילד התחבא מתחת למיטה. כשהאם ראתה את הסרטון הזה, היא אמרה, כשאמר שהילד התחבא מתחת למיטה, הייתי מופתעת. לא ציפיתי לכך, משום שאני מאמינה שיש מפלצות וצריך לגרש אותן. ציפיתי שיחזור על המילים שלי, לגרש את המפלצת, אבל לא, הוא מצא פתרון אחר. והייתי מופתעת. אנחנו תמיד מגרשים מפלצות. אף פעם לא אמרתי לו להתחבא מתחת למיטה. אף פעם לא אמרתי לו שאין מפלצות. אנו מבינים עכשיו יותר טוב למה האם אינה מקבלת את האמירה של רון שאין מפלצות. בשבילה צריך להילחם במפלצת, צריך להיות אקטיבי. לצערנו, בחוויה של מי שנפגעה מינית, מפלצות היו אמיתיות, ולא ניתן היה פשוט לומר אין מפלצת. כאן אנחנו מתחברים לרפלקטיביות ההורית, או יותר נכון לקשיים שלהם, להראות רפלקטיביות כזאת. מצד שני, אנחנו רואים אצל האם הזאת גם הפתעה, וההפתעה הזאת, לראות משהו לא צפוי, זו דלת כניסה אפשרית לטיפול, כמו שהעבודה המרשימה של אריאטה מדגימה לנו. תודה רבה.
דוד, המון המון תודה. אני כל הזמן חושבת איך פטרישה הייתה מתרגשת לראות את שניכם, כן, מדברים, ועל העבודה הכל כך חשובה שכולנו עושים. יש שאלה אחת, או רגע, יש שאלה אחת בשבילך, דוד, מאוסנת, איך מתייחסים להגדרה וסוג ההתקשרות לאותם תינוקות שגדלו בבתי היתומים של רומניה, ולמעשה כמעט לא חוו כלל שום התקשרות, אפילו התקשרות בלתי מאורגנת. אינה מתאימה כאן.
כן, אז מה היה? כן, זה זורק אותנו למשהו אחר. מה הייתה התחלת השאלה? איך
מתייחסים להגדרה וסוג ההתקשרות לאותם ילדי רומניה?
אז אוקיי, אנחנו הולכים למקום אחר פה, אבל אני אענה, אם מדברים על הילדים האלה, כאשר הם היו במוסדות האלה שבהם לא התקיימו התנאים להתפתחות של התקשרות, אז זאת תהיה אולי הדוגמה היחידה של ילד שאנחנו נקרא לו non-attached. זה נדיר מאוד, כי אחד מהדברים שאני חושב יותר רלוונטיים לענייננו, זה שילדים מפתחים התקשרות גם כלפי הורים שפוגעים בהם בצורה חמורה ביותר. ואני חושב שזאת הנקודה שדווקא אנחנו צריכים להדגיש אותה ולהבין אותה, ואני חושב שאריאטה ואחרים כל כך עוזרים לנו להבין את זה, את הפרדוקס הזה, למה ילד מתקשר להורה שפוגע בו בצורה כל כך נוראית. והסבירה את זה, אני חושב, אריאטה היום, מבחינת המנגנון הפסיכוביולוגי הזה, שאומר לנו ללכת אל מי שיכול להגן עלינו. והמנגנון הזה לצערנו עובד גם כאשר האדם הזה שאמור להגן עלינו לא מגן עלינו, ורק דבר אחד להגיד בסוף, אלישה תמיד אומרת, even an abusive parent is not always an abusive parent. זה גם כן דבר שצריך לחשוב על המורכבות של החוויה של אינטרנט.
תודה. Arietta, would you like to add anything?
No, I'm so impressed with David's ability to say what I wanted to say so clearly. Thank you so much for that discussion, David. I really, really appreciate it.
ואנחנו סיימנו עוד שנה, כן, 9 שנים. אני רוצה גם מאוד להודות למתורגמנים, שפעם ראשונה שאנחנו, או לפחות הפעם ראשונה שאני חוויתי את החוויה הזו שכולם מבינים ולא משנה באיזה שפה מדברים. זה מאוד מאוד אפשר ותודה רבה לכם. וגם להילה סוהמי שהייתה איתנו. Professor Oppenheim and Professor Slade, thank you so much for being with us. And we hope to hear from you
so
again
much.
soon.
Thank you.
Thank you.
Bye-bye. שלום לכולם.
Bye.
Bye-bye.